Okay, it is now 3, so I'm going to start. Welcome to the 3rd edition of the National Virtual Leukemia Conference. This one-of-a-kind conference addresses the unique needs of the blood cancer community and offers the latest information, tools, and resources to help support Canadians touched by leukemia. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation, Changing Treatment Goals for Acute Lymphoblastic Leukemia. Are you and your healthcare team on the same page? In this session, Dr. Don Mays, a member of the Leukemia Program and the Elizabeth and Tony Comper MPN program at the Princess Margaret Cancer Centre, will address treatment of acute lymphoblastic leukemia, advances in research, and management of ALL side effects. Before we begin, let me introduce myself. I am Brooke Dewhurst. I am the Community Services Lead for the Atlantic region here at the Leukemia and Lymphoma Society of Canada, and I will be your moderator for the online event today. We invite you to type your questions and comments into the Q&A box on your Zoom webinar panel throughout the presentation, and we have a staff member here who is going to monitor the questions, and I will read some of them out loud at the end of the presentation. Due to the large number of participants and limited time, we may not be able to answer all of the questions. And also note that Dr. Mays cannot answer specific personal questions about a person's health, history, or status. Today's presentation will be recorded. It's being recorded right now, and therefore you can rewatch it again on our website. You can go to the next slide, Dr. Mays. As we come together across Canada, we recognize that we are on the lands of many Indigenous nations. We honor First Nations, Inuit, and Métis people whose deep connections to these lands enrich our communities across Canada, also known as Turtle Island. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, and belonging, and health equity guides how we work to support and uplift everyone affected by blood cancers. You can go to the next slide, please. Are you looking for a specific program or resource and not sure where to find them? Well, we are here to help. You can connect with any community services lead in your area across Canada to receive personalized assistance and get connected to resources in your area. You can reach out to us by calling the toll-free number 833-222-4884, or by accessing our individual contact information on the website. Go to the next slide, please. We know that having a diagnosis of ALL can be very overwhelming, but know that you are not alone. There's a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-on-one support to help you navigate the blood cancer experience. Next slide, please. We invite you to visit our website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. And there's the information there. Next slide, please. On our website, you will find tailored information and resources in multimedia formats to address the variety of needs and preferences, including those specific to ALL. This includes fact sheets and booklets like the ones you see here on your screen. Next slide, please. We also have a podcast channel called The Blood Cancer Experience. Find hundreds of podcasts for people touched by a blood cancer, many addressing challenges that people living with ALL face. We speak to experts about the current topics such as treatments, diagnosis, and research. We will also hear personal stories from people touched by a blood cancer. We have information and resources to watch like the previous webcast and animated video on ALL, understanding diagnosis, treatments, options, and side effects. Visit bloodcancers.ca to read, listen, and watch all of these really great resources. Okay, next slide, please. So we launched in October the LLSC's Travel to Treatment study. This study is to measure and quantify how traveling for cancer treatment affects individuals and families. We want to gather and present information to decision makers to help them understand the real-life impacts of having to travel to treatment to improve support for individuals affected by blood cancer. The study will examine factors contributing to individual experiences, including finances, education, housing, and employment to see how travel affects these important life factors. Please use the survey, fill out the survey using the QR code here, and you will also receive a link to this survey in a follow-up email 24 hours after the session. Next slide, please. It is now time to introduce today's speaker, Dr. Dawn Mays. Dr. Mays is an assistant professor in the Department of Medicine at the University of Toronto and a clinician investigator at the Leukemia and Myeloproliferative Neoplasms programs at the Princess Margaret Cancer Centre. Her interests include risk stratification and management of acute leukemia and NPN, particularly in the adolescent and young adult population. She is the primary investigator or co-investigator on several enrolling and upcoming clinical trials of novel therapies for myeloid neoplasms. She is currently serving as the medical director for the Malignant Hematology Day Unit at the Princess Margaret and as the director for the Leukemia Fellowship Program. Thank you so much for being here with us today, Dr. Mays, and I will now turn it over to you.
Great. Thank you, Brooke. And thanks everyone for joining us today. It's a pleasure to be here today to talk to you about ALL. So this is a disease in which really there have been some remarkable advancements over the past decade or so, and I'll try to highlight some of these. But as you'll see, ALL is a genetically quite heterogeneous disease, and certainly there are some areas where ongoing research is needed. So this is our agenda for today. So we'll cover what ALL is, typical signs and symptoms, tests that we use to make the diagnosis and help with treatment planning. We'll talk about some drugs that are used in both the upfront and relapse refractory setting, as well as the place of stem cell transplant. We'll talk about how clinical trials can fit into the treatment. And then finally, we'll talk about some long-term follow-up, potential long-term and late effects, and survivorship. So first, let's talk about blood. I think many people will be familiar with this, but just by way of background to ensure that everybody's on the same page, I've included it. So we all have three main types of blood cells. We have white cells that help us to fight infection, red cells that carry iron and oxygen, and platelets that help the blood to clot. And those blood cells are carried in plasma. That's the liquid part of the blood. The plasma is made up mostly of water, but it also contains vitamins, minerals, proteins, and some other chemicals. In adult life, most blood cell production happens in the bone marrow, and that's in the center of the bones. So as shown in the figure, blood cells develop or differentiate from blood stem cells, and they can progress along a myeloid or lymphoid lineage. Myeloid stem cells give way to red cells, platelets, and some types of white cells, including neutrophils. And lymphoid stem cells give rise to B cells, T cells, and natural killer cells, all of which are an important part of the immune system. Lymphocytes are found in lymph nodes, which are located throughout the body, and they're also found in various other lymph tissues, including the spleen, thymus, tonsils, and others. And lymphocytes move throughout the body in lymph vessels. These smaller lymph vessels connect with lymph ducts, which ultimately drain into the blood. And so these ducts link the lymphatic system and the blood system. And it's how lymphocytes travel between the two systems. So with that introduction, let's talk about leukemia. So leukemia is a type of cancer of the marrow and blood. And in 2024, over 47,000 Canadians are living with or in remission from leukemia. And nearly 4,000 Canadians will be diagnosed with leukemia. On this slide, you can see the four most common types of leukemia. And these are divided by which lineage that I showed, whether they're myeloid or lymphoid, and also whether they're acute or chronic. These are the most common types of leukemia, but in fact, there are many others. How does leukemia develop? So like all cancers, leukemia begins with one or more genetic changes that leads to cell transformation and uncontrolled cell growth. Where on that developmental pathway the mutation occurs and the rate of growth of the cells is what determines the type of leukemia that develops. Again, whether it's acute or chronic leukemia and whether it's myeloid or lymphoid. In the case of ALL, the transformation occurs in a cell that's a precursor to a mature B or T lymphocyte. This is known as a lymphoblast. So instead of following the normal developmental pathway and maturing into a mature B or T lymphocyte, these cells have a transformation and they get arrested at the lymphoblast stage. And then these cells grow in an uncontrolled way. These abnormal cells are not subject to the normal mechanisms that control cell growth. And this does two main things. So the cells growing and expanding in the bone marrow prevents normal healthy blood cell production in the marrow. And these cells can also end up in other tissues, in the lymph nodes and some of the other lymph tissues we talked about. And they can also cause some other problems that we'll discuss. So if we look at the incidence of ALL, it has an unusual pattern of age distribution. With other types of leukemia, the incidence rises as we age. With ALL, there's a bimodal age distribution. So it's actually most common in children between the ages of 1 and 4. And then the incidence decreases until about the age of 50, 55. And at that point, it slowly increases again, particularly in men. The cause of ALL is not known, but there are a few factors that have been associated with an increased risk. These include exposure to chemotherapy or radiation previously for another type of cancer. Certain genetic disorders increase the risk, the most common one being Down syndrome. Age, as we just saw, so young children and adults over the age of 70. Gender, so males are slightly more likely than females to develop ALL. And US data also shows that ALL is more common in Hispanics and whites. Patients will often ask if there's anything that they did to contribute to ALL. And the answer is no. There's no known association between diet, lifestyle, habits, or other things. So we don't know why most people get the disease. So now we'll talk about the signs and symptoms of ALL, but first, just a few definitions. So a symptom is something that a person experiences subjectively, and a sign is a manifestation of the disease that can be observed by someone else. This is objective. So an example of a symptom might be a headache. An example of a sign could be a bruise. So it can be objectively seen. And when we're talking about signs and symptoms of ALL or any leukemia for that matter, we often use the terms that I've included here below. So anemia refers to low red cell count. Thrombocytopenia refers to low platelets. And neutropenia refers to low neutrophils. That's an important type of white cell that helps to fight infection. And many of the signs and symptoms of ALL are related to having those low blood counts. So when people are anemic, they can experience fatigue, shortness of breath during normal activities, lightheadedness, dizziness. Neutropenia, low neutrophils, can result in fever or frequent infections. Having low platelets or thrombocytopenia can result in easy bruising, prolonged bleeding from minor cuts, or tiny spots on the skin known as petechiae, typically in the lower extremities. Other symptoms of ALL unrelated to the low blood counts include things like night sweats, change in appetite, weight loss, pain in the joints or bones, or enlarged spleen, liver, and lymph nodes. These are some of the tests that we use to diagnose ALL. So the assessment typically starts with a complete history and physical exam. We'll do blood work, including a complete blood count with a differential, as well as other blood work, such as chemistry to look at organ function. We'll do a bone marrow aspirin and biopsy. Immunophenotyping or flow cytometry is done to help us define the cell type. So this looks at the pattern of proteins or antigens on the cell surface. We'll do a lumbar puncture, otherwise known as a spinal tap, and this is to sample some of the fluid that bathes the brain and spinal cord to determine if there are any cells, leukemic cells in that fluid. We also do a number of different genetic tests, including cytogenetic analysis, FISH, and PCR, and in some cases, imaging like CT, MRI, or PET scans may be done. These are the two main subtypes of ALL. So there's B cell and T cell, and that relates back to the developmental pathway I showed. So B cell ALL begins in immature cells that would normally develop into mature B lymphocytes. This is the most common ALL subtype, representing about 75% of cases. And T cells begin in those T lymphoblasts that would normally develop into mature T cells. This is less common in about 25% of cases. But beyond this subdivision, genomic studies are identifying new subclassifications based on chromosome rearrangements or other gene mutations. And many of these entities will have unique clinical features or will impact the prognosis. And it is the hope that being able to refine the classification will lead to better risk stratification and a more personalized approach to treatment. For example, in patients who have higher risk disease, they may require more intensified therapy or even stem cell transplant earlier in the disease and first remission. Whereas some patients who have lower risk genetics may be able to have de-escalated therapy and spare some of the toxicity that comes with treatment. At present time, the most important recurrent genetic abnormality in ALL is the Philadelphia chromosome. So Philadelphia chromosome positive ALL or PH positive ALL is a subtype of ALL that results from a specific mutation resulting in an abnormal BCR-ABL gene. And approximately 25% of patients with ALL will have this gene. And this is quite important because the treatment of this subtype is unique. So in addition to the chemotherapy backbone that we'll soon discuss, medication is also added to target this genetic mutation. A number of factors can impact the outcome, and these are often categorized into patient-related factors and disease-related. So patient-related factors are those that relate to the patient and their specific situation, and they include things like the patient's age and their general health, prior chemotherapy, whether they've had treatment for another type of cancer, social factors, like whether they have a caregiver, or if there are social circumstances that might result in treatment delays. And then disease-related factors include things like higher white count at diagnosis, the immunophenotype of the cells or the genetic composition, whether there are ALL cells in the CNS, the central nervous system, or other sites outside of the bone marrow, whether there's active infection or other medical problems at the time of diagnosis, and the timing of response to initial therapy. So what I mean by that is how quickly the cells are killed off with that first treatment. So treatment planning has to consider all of these aspects. So the details of the disease, along with the age, health, personal, and social circumstances of the patient. A few quick facts about treatment planning. So ALL is usually treated by a hematologist with a focus on hematologic or blood cancers. Given the complexity of ALL protocols, it is important that treatment be planned at a center where there's experience in the care of patients with acute leukemia. However, in some cases, parts of the treatment can be given in community hospitals, and this is known as shared care. In general, patients with ALL need to have a diagnosis made and treatment started as soon as possible. But in some cases, there may be pre-treatment considerations, such as fertility preservation, or there could be active infections or medical issues that need to be addressed prior to starting chemotherapy. So this figure outlines the different phases of a typical ALL protocol. There are several different protocols which vary in terms of the exact drugs and doses, but the basic treatment principles are the same. So ALL treatment is typically divided into different phases. There's an induction phase that typically lasts about a month, and the goal of this phase is to achieve complete remission. After induction, usually a consolidation or intensification phase, which is used to deepen the remission and kill any remaining leukemia cells. And this is often given in repeated cycles. And then finally, there's a maintenance phase that typically lasts 18 months to 2 years. Again, this is typically multiple drugs given in cycles, and the purpose of this phase is to prevent relapse. There are several different drugs that are used to kill ALL cells, and each drug works in a different way. So combining them makes the treatment more efficient. Induction backbones typically contain the drugs that you see here. So steroids are a very important part of the treatment. Usually the protocols include anthracyclines, a vinca alkaloid like vincristine or vinblastine, and then a pegasparaginase preparation. Again, once remission is achieved, then there's usually an intensification or consolidation followed by maintenance. And these are some of the drugs that can be used in these phases. And the best outcomes with ALL therapy are seen with repeated cycles of multi-drug therapy. And all of these drugs have an important role in the therapy. And we know that skipping doses or unnecessary delays increase the risk of relapse. So for example, this was a study in which patients didn't receive all the planned asparaginase doses. So this was children actually with high-risk disease. And the children who missed the doses had an inferior outcome, poorer disease-free survival than patients who received all the pegasparaginase or received a different preparation of pegasparaginase. So we really try to minimize any treatment interruptions or missed doses as much as possible. Another important aspect of any ALL protocol is CNS prophylaxis. So the CNS stands for central nervous system. This is the brain and spinal cord. At diagnosis, it's fairly uncommon for ALL to involve the CNS, about 3 to 7%. However, without treatment directed specifically at the CNS, there's a very high risk, probably about 50%, that the disease will impact the CNS. CNS prophylaxis is typically given throughout the protocol, and in some protocols, there's a dedicated CNS phase. It's usually given intrathecally, which means during a lumbar puncture, the chemotherapy is injected directly into the fluid that bathes the brain and spinal cord. But in cases where there's already CNS disease at diagnosis, treatment can be given intrathecally, but is also often given systemically through a vein, and less commonly, radiation will play a role. So in addition to the conventional chemotherapies that I've talked about, there are a number of immunotherapies that are currently being used in ALL. In most centers at present, These are being used to treat persistent or relapsed disease. However, there are a number of clinical trials, both completed and ongoing, that are showing promising results by incorporating these immunotherapies early in treatment in the frontline setting. So I think this is something that we're quite likely to see in the near future. I've alluded to this already. In Philadelphia chromosome positive ALL, we have to target the Philadelphia chromosome specifically. So in addition to the chemotherapy backbone that I've already described, a class of drugs known as tyrosine kinase inhibitors will be included, and the common drugs that we use are listed here. I wanted to mention the older adolescent and young adult population specifically. This group is variably defined, but usually refers to patients aged 15 to 39. And historically, these patients have been treated either on pediatric protocols or adult protocols, depending on the center. Generally speaking, pediatric regimens tend to be more intensive, more complex. They include more pegosparaginase, more steroids. They're given for longer periods of time, and they may include CNS treatment that's given earlier or longer. And a number of studies now and a meta-analysis have found that AYA patients have improved long-term outcomes and a reduced risk of relapse if they're treated with pediatric protocols. So this has really become the standard of care for patients in this age group. Another concept I wanted to talk about was that of measurable residual disease. So we discussed earlier that the goal of induction chemotherapy is to obtain complete remission, and that's defined as less than 5% blasts in the bone marrow, and that's a very important milestone. However, even after achieving remission, small amounts of residual cells, known as measurable residual disease, can remain. And studies have shown that the presence of MRD is a very powerful prognostic indicator. And so treatment is often modified based on the detection of MRD. So one strategy to target MRD is blinatumomab. So blinatumomab is a type of immunotherapy. It's known as a BiTE, or a bispecific T-cell engager. And so it is an antibody construct that allows the patient's T cells to recognize and eliminate CD19 positive blasts. And in an important clinical trial of patients with MRD positive B-ALL, 78% became negative after one cycle, and 2/3 of patients were able to go on to allogeneic transplant. So a couple of words on allotransplant. So a stem cell transplant is a procedure in which a patient receives stem cells from another person. In some situations, in some high-risk patients, allogeneic transplant may be offered in first remission. However, increasingly commonly, allogeneic transplant is being reserved for patients who have relapsed or have persistent disease and then have achieved a second remission. A stem cell transplant is an intensive procedure which may be associated with a number of important complications such as infection and graft versus host disease. And historically, this was restricted to younger and fitter patients. However, in recent years, there have been reduced intensity transplants. So this is something that is now being offered. This involves a lower intensity chemotherapy, and it's allowed the procedure to be used for patients who may be older or less fit. So allowing more patients to be able to avail of that treatment. However, as I mentioned, a stem cell transplant is quite an intensive procedure, and it is a complex decision. Whether to pursue that requires discussion between the patient, their family, and the healthcare team. Factors that influence whether transplant is an option include the patient's age, their ability to tolerate intensive chemotherapy, the cytogenetic and molecular characteristics of the ALL cells, the availability of a suitable donor, and availability of a caregiver. So most patients with modern ALL protocols will achieve remission. However, some patients have residual leukemia cells after induction, more than that 5% threshold for complete remission, and that's referred to as refractory leukemia. In other cases, patients may achieve a remission and then the leukemia returns, and that, of course, is a relapse. In general, relapsed and refractory disease is more difficult to treat. At the time of relapse, the immunophenotypic or genetic characteristics of the cells may be different, so sometimes some of the testing is repeated, and this can affect treatment decisions. For relapse disease, if there is a clinical trial available, this is a good option to consider. Outside of trials, second-line therapies for B-cell ALL typically include immunotherapy. So this may include blinatumomab, inotuzumab, or CAR T-cell therapy, which we'll touch on. In the case of Philadelphia positive ALL, the TKI, or the tyrosine kinase inhibitor, is typically changed as well. Relapsed TALL remains challenging, and salvage treatment typically involves chemotherapy, possibly with the addition of nelarabine. And then, as we've already discussed, often an allogeneic transplant is considered for relapsed or refractory ALL once a second remission has been achieved. So blinatumomab, this is the BiTE therapy that we talked about earlier in the context of MRD. It's also been shown to be quite effective in relapsed refractory ALL. So in a large randomized study known as the TOWER study, 405 patients with relapsed or refractory B-ALL were randomized to receive blinatumomab or chemotherapy. More patients in the blinatumomab arm achieved remission, and in patients that did, the remission duration was longer in those that received blinatumomab. Similar results were seen for inotuzumab. So inotuzumab is an anti-CD22 antibody linked to a cell toxin called calicheamycin. And so the conjugate recognizes ALL lymphoblasts that have CD22 on their cell surface and kills the cells with the calicheamycin. In another randomized study, the Innovate study, 326 patients with relapsed and refractory B-ALL were again randomized to receive either conventional chemotherapy or inotuzumab. And the patients in the inotuzumab arm were more likely to achieve remission, and the remission duration was also longer. So another new therapy is chimeric antigen receptor T-cell therapy. So in this therapy, a patient's own T cells are collected and re-engineered in the lab to produce chimeric antigen receptors, or CARs, on their surface that can recognize and kill lymphoblasts. So these cells are grown in the lab. The patient is given a short course of chemotherapy called lymphodepletion to get rid of the normal T cells that the patient has. And then the CAR T cells are reinfused and attack the cancer cells. There are currently 2 products that are approved in Canada and commercially available. Kymriah is for children and adults up to 25 years of age. And Tecartus is for adult patients. And as you can see, in clinical trials, both have shown really excellent results in relapsed and refractory patients. That brings us to clinical trials. So clinical trials are carefully controlled research studies that are designed to advance the care of patients with cancer. And clinical trials are intended to give patients safest, and hopefully most effective therapies. And at diagnosis, or anytime there's a change in therapy, clinical trials should be considered. Trials are not only for patients with advanced disease, and we shouldn't be waiting for standard treatments to fail before considering trials. Clinical trials can be designed to look at new drug therapy for the disease itself, or it can be looking at some aspect of supportive care or quality of life, like infection prevention, for example. These are some of the current clinical trials that are open in Canada for ALL. We have some in the upfront and relapse refractory setting. I'm not going to go through these, but if this is something of interest, you should certainly talk to your doctor or team about options. So switching gears now to talk about some of the treatment side effects and complications. Many of the side effects from treatment are related to low blood counts. So we talked about this earlier in the context of signs and symptoms of the disease. So the disease can cause low blood counts, and then treatment can temporarily make this worse. So again, symptoms of complications of the treatment can include symptoms of anemia, like fatigue, shortness of breath, dizziness, neutropenia, so treatment increases the risk of fevers, infection, and thrombocytopenia, which can increase the risk for bleeding and bruising. Patients with ALL are also at risk for something called tumor lysis syndrome. And this is a particular risk for patients who have a very high white count at diagnosis. So when treatment is started and those leukemia cells are killed quickly, they break apart and release their contents into the bloodstream. This can cause electrolyte disturbances, and it also can overwhelm the kidneys. The kidneys can't get rid of the substances quickly enough. So that's tumor lysis. Steroids, which again are an important component of all ALL protocols, they can affect mood, sleep, blood sugar, particularly in patients who have diabetes, and they can also cause long-term bone complications. Vincristine can cause neuropathy or nerve damage, and that typically starts as a numbness or tingling in the fingers or toes. And asparaginase, another key component of pediatric protocols in particular, can cause hypersensitivity reactions, liver toxicity, pancreatitis, and blood clotting abnormalities. But there are many treatments that we use to prevent and manage side effects. One of the simplest and most important measures is good hand hygiene. Sick contacts should also be avoided and vaccinations kept up to date. Transfusions can improve anemia and thrombocytopenia, and sometimes growth factors can be used for neutropenia. Medications, of course, are used for nausea and vomiting, both prevention and treatment. And we use medication to prevent and treat uric acid buildup in the tumor lysis syndrome that I just described. Blood thinners can be given to help reduce the risk of blood clotting in patients on asparaginase. And we also give medications to try and minimize bone loss, including bisphosphonates, calcium, and vitamin D. So we have many new drugs that have improved our ability to manage side effects. And as well, some of the side effects can be mitigated with lifestyle changes like good nutrition, physical activity, and infection risk reduction. However, in some cases, side effects can be more difficult to manage, and sometimes we involve our palliative or supportive care colleagues to help. Palliative care is anything that aims to help minimize symptoms and improve quality of life. And this can be included at any stage of disease. I think some people still equate palliative care with end-of-life care, but they're not the same thing. And palliative care can be used alongside of curative therapy to, again, improve quality of life. Complementary therapies may also be an option, but certainly discuss any therapy you're thinking of taking with your team before starting. So protecting a weakened immune system, we've already talked about a little bit. So people with leukemia and indeed any kind of blood cancer are more susceptible to infection as a result of both the disease and the treatment. Measures to help reduce the risk of infection include washing hands regularly, avoiding sick contacts, avoiding crowded spaces if at all possible, and if unavoidable, consider masking, receiving appropriate vaccinations, and in some cases, prophylactic antimicrobials may be recommended. It's recommended that immune-compromised adults have a yearly flu shot, up-to-date COVID-19 vaccination, and pneumococcal vaccination. And the non-live shingles vaccine, Shingrix, can also be considered. Live vaccines such as measles are not recommended for immune-compromised people. And again, if you're wondering about a vaccination, if you're thinking about taking something, talk to your doctor or team before proceeding. So patients who complete ALL therapy are at risk for both long-term complications and late effects. Long-term complications are medical problems that last for months or years after the treatment ends. And late effects are medical problems that don't show up or get noticed until years after the treatment ends. ALL survivors are at increased risk for a number of chronic health conditions, including cardiovascular conditions like hypertension, dyslipidemia, reduced heart function, metabolic effects like impaired fasting glucose, diabetes, or obesity. Secondary cancers are increased in ALL treatment survivors. Bone health abnormalities like low bone density, osteoporosis, or osteonecrosis. Psychosocial concerns like anxiety and depression, and neurologic effects like cataracts and neuropathy. A survivorship care plan should include monitoring for these conditions because early detection, of course, will ensure the best management. So once ALL treatment ends, regular follow-up is required indefinitely to look for signs of relapse and also to monitor for long-term or late effects. And at that stage, a survivorship care plan typically involves shared care between the hematologist and the primary care provider and may include other members as well, including physiotherapists, dietitians, psychologists, or others. Finally, healthy lifestyle habits are associated with improved long-term health outcomes and quality of life. And these include things like well-balanced food choices, regular physical activity, limiting alcohol and tobacco, wearing sunscreen, protecting your skin, vaccinations, as we've discussed, and stress management. So I think that was the last slide. So we've talked about genomic studies, how they're improving our understanding of ALL. We've reviewed ALL protocols and talked about how typical treatment protocols involve different phases of multi-drug therapy. We've talked about the role of immune therapies and stem cell transplant and how they're typically used at present for persistent or relapsed disease. We've talked about long-term follow-up, monitoring for relapse, as well as long-term and late effects. And then finally, there are many strategies to help manage these effects and improve quality of life. So I think with that, I will end and take any questions.
Hello. Okay, thank you for that. Yeah, we do have a few questions here. And the first is, are there currently any studies or modifications in the works to look at the 3-year versus 2-year maintenance period for boys versus girls?
That is a very specific question, not that I am aware of, certainly not in Ontario. I cannot necessarily speak to what studies might be at other centers.
Okay, thank you. And the next question is, are there any correlation between some severe side effects, more sensitive and more sensitivity to toxicity and specific genetic mutations?
That's an interesting question. So, so I think that's an active area of research. There are some gene mutations that we're aware of, including inherited gene mutations that increase toxicity. One, for example, is the TMPT gene. So there are things like that. I think it is quite likely that some of the recurrent genetic mutations that are being discovered will also impact the way people respond to treatment, but it's an active area of study. And I don't think at this point in time, there are definitive conclusions, and certainly we're not modifying therapy yet based on these gene mutations. I think it's quite likely in the future though.
Okay, thank you. Another one we have is, what are the palliative care resources available and where to find information related to this?
So this again is going to vary by center. So I think the best starting point is your own doctor and care team, and they can talk about the survivorship resources that are available at your center. They will often include things like psychosocial support. Many centers have cancer rehab programs or survivorship programs. Some of them have programs specifically geared toward subgroups like AYA patients or older adults with cancer. I imagine that LLSC would be able to help with some of those resources as well. But I think your own team would probably be the place to start because it's going to be a bit center specific.
Yeah, our CSLs in each region across Canada can definitely look into that for folks. So definitely reach out to us if you have any questions specific to your location. The next one we have is, are you aware of ALL outside the bone marrow?
Yes, so usually, as we talked about, ALL will affect the bone marrow and blood. It certainly can occur outside of the bone marrow. One of the most common places then would be lymphatic tissues. So in the lymph nodes, spleen, liver, it can, as we talked about, rarely affect the CNS, but it actually can affect any organ or tissue. So these are less common. It's called extramedullary disease. And it certainly can occur and sometimes requires unique treatment approach.
Thank you for answering that question. And next we have, is it the patient's responsibility to request information regarding clinical trials, or is this something that the healthcare team would bring up?
So no, I think typically the healthcare team will bring this up. If there are suitable trials and the team thinks that there might be a good match for the person and their particular disease, usually this will come from the team. I think sometimes when it is not discussed, it is because there's not an applicable trial. At many centers, there are multiple trials open at given times, but the inclusion and exclusion criteria are quite specific. So if you're not hearing about it, it may be because there's nothing suitable at that, for this particular disease stage. But I think it's always good to ask. It never hurts to ask the team if there are any trials and express interest in trials. And I think that also alerts the team that that it's something you might be interested in the future if applicable.
Okay, thank you. And the next one is, CAR T available to all adults in Canada?
So I do believe So it is certainly, so the two products that I mentioned are approved in Canada. And, I'm aware of the funding in Ontario. This is where I am located. So I find that speaking to funding in other provinces is tricky. I'm going to try and avoid that and suggest that you talk to your own healthcare team. But both of these products have demonstrated efficacy in clinical trials and are Health Canada approved.
Thank you. Just a few more here. When might you see those post-treatment related complications occur? Are there timelines for this, for example, for metabolic syndrome, diabetes, etc.?
Yeah, so it's an interesting question. And I think it's probably not well defined. Truthfully, most of these studies have been done in pediatric ALL survivors. This is where most of the data is coming from. So children are exposed to these treatments early in life, and then we know that they are at increased risk for these complications later in life. A lot of these complications are things that are seen in the general population, and we know that they're increased in people who've been through chemotherapy. But to answer the question, like, are there specific timelines? Really, no. I think that hasn't been well defined by the research that exists.
Thank you. And another question we have about maintenance length is, what is the reasoning for boys having longer maintenance period in pediatric ALL? Is it because increased risk of relapse?
So I'm an adult hematologist, so I really, I'm going to stay away from the pediatric space so that I don't give incorrect information. In adult ALL and in the treatment protocols we use, we do not offer different lengths for boys and girls. So I'm afraid that's one that I'll ask you to direct to your own pediatric hematologist, please.
Thank you. And the last one we have here is the Dana-Farber less than 60 protocol considered a pediatric treatment?
It is.
Okay.
It is, yeah. So the Dana-Farber under 60 protocol is one of several standard pediatric protocols. And then a typical adult protocol would be something like hyper-CVAD.
Okay, thank you. And I think what we'll do now, I don't see any more questions. Oh, I think one just popped in. Someone says that their husband is having CAR T as a bridge to stem cell transplant. Has CAR T proven to achieve long-term remission?
So, there are a lot of open questions, I think, still in ALL. So I think with CAR T, there are the products that are currently available in Canada, and there are a number of other products in studies as well. Long-term remissions after CAR T cells are possible, but there are certainly patients who relapse as well. And at the present time, we're unable to identify who those patients are proactively. So transplant is often discussed at this point in time after CAR T cell as a way to try and reduce the relapse risk. But it's an active area of study. The relapse risk seems to vary by product. So it's, these are very individualized decisions at this point in time.
Okay, thank you so much, Dr. Mays, for answering those questions. And thank you so much for coming today. Your expertise and experience is very valuable to us, and we're really grateful for you to come and spend time speaking today. And I'm just going to ask that you go to the next slide now. So before we sign off today, I'd like to remind everyone of our upcoming conference. Well, we have just one more this week. The last one tomorrow is how to actively participate in your cancer care. And it is tomorrow from 1300 to 1400 Eastern time. And we'll go to the next slide. We'd also like to thank AbbVie, Astellas, AstraZeneca, Bristol Myers Squibb, Jazz Pharmaceuticals, Johnson & Johnson, and Novartis for their support in making these conferences possible. And the next slide, please. Please remember that we are here to help you. You can reach us by email, by visiting our website at bloodcancers.ca, or by calling us toll-free. And just a reminder that a short survey will be sent to all participants after the presentation. If you can, please take a moment to respond, as it really helps us plan future events. And we'll go to the next slide. And yeah, it's just thank you. Thank you all for being here today. And this is the end of the session. We just have ended a few minutes early, but thank you all for coming, and take care.
Thank you.